So without further ado, I'm sorry? Yes. There was an error message when I came up here. All right, I'm going to start anyway. You guys are all here, so you're going to benefit from this lecture regardless of if there's an issue technically. So good job on coming to class. All right. So skin and soft tissue infections. Every time I get an APPE student on rotation, they're always so shocked at how many of these they end up encountering in the hospital. They always go, Dr. Worley, I didn't really realize how common skin and soft tissue infections are until I came on your rotation. And my team at Jackson is actually family medicine team, so we're internal medicine, family medicine. We take pretty much anything and everything. And even with that, kind of getting anything and everything, we end up getting so many patients that are admitted for treatment of skin and soft tissue infections. And so this is a very, very common thing you will see both on the inpatient side and on the outpatient side as far as the type of infectious diseases that you'll encounter regularly. Today, our lecture objectives would be to be able to recognize the epidemiology as well as etiology of
Excuse me, Professor?
infections. Sorry, do I have a question?
We can see your slides.
That's a really good point. Thank you. See, I want you guys to ask questions. Sorry about that. All right. Here we go. Now we're showing the right thing. Okay, I was thrown off by the counter error. All right. I want you guys to be able to list the most common offending microbes associated with each skin and soft tissue infection. I also want you to be able to evaluate treatment for each skin and soft tissue infection. So if I give you an example case, I want you to be able to tell me, is this going to cover the most likely organisms, and is this appropriate given the patient's severity of presentation? I also want you to be able to recall preferred treatments. And this includes dosing. Oh no, you guys hate that, memorizing dosing. But believe it or not, you've seen all of these drugs before, okay? So this is repetition from stuff that you've seen already in PT4. So you will be very familiar with the names of these drugs. So this is all just kind of hopefully cementing it in your knowledge as far as the doses that you're going to encounter, as well as the frequency and route and duration of therapy. Okay, so a little bit of background. As I said, this is a super common thing that you will encounter in clinical practice regardless of your practice setting. There's many different types of skin and soft tissue infections, okay? I listed here the main ones that we're going to be talking about today, which includes impetigo, cellulitis, necrotizing skin infections, follicular infections, abscesses, animal bite wounds, osteomyelitis, as well as diabetic foot infections. Okay, so a little bit of definitions here. This is probably mostly just relevant to those of you who are really interested in literature reviews and potentially looking at industry. But there's a new definition for skin infection, and it's the definition is acute bacterial skin structure infection. And this was done really to try and make the trials for different new antibiotics a little bit easier to interpret, because they were seeing trials on different antibiotics for skin infections using a lot of different patient populations, and so they were not thinking they were very comparable if they were looking from one trial to another. So they sought to try and make that population a little more defined, very specific. And so for this definition for antibiotic approval purposes, the definition is cellulitis erysipelas, or a wound infection, or a major cutaneous abscess. And the minimum lesion surface area had to be about 75 centimeters square. Okay, so this is a very, very specific definition. And it kind of eliminates a couple other regular conditions that we do see as far as to be included in these clinical trials. So other things that are included in the skin and soft tissue infection guidelines, as well as the things we'll see in clinical practice that are not included in this indication via the FDA's approval, would be less serious infections, like something that's more superficial, like impetigo, minor cutaneous abscesses that are not big enough to be considered large enough for SSTI, sorry, 3 S's, and then more complex types of skin infections, like an animal or human bite wound, as well as necrotizing infections. So these are too severe to be considered in that definition. And we're going to be talking about all of these things today. But I just want you guys to know that if you're looking at clinical trials, you do need to look at the patient populations they're including, because this has been recently defined a little bit more specifically. So if you're doing a drug comparison, you have to look at exactly what population they're including. Additionally, we're going to briefly mention, but not go over in great detail, some skeletal infections, specifically osteomyelitis. I'm not going to really touch on septic arthritis. Both of these things are fairly common, but you guys, I don't want to confuse you guys with too much material all at once. So we're going to go over the most common things that you're going to see in clinical practice, which would be more or less your more superficial infections, cellulitis, some of the cutaneous abscesses, and we're going to briefly go over osteomyelitis. So two major guidelines that I'm going to be referencing throughout this presentation would be both of the IDSA guidelines. One of them is a guideline on the treatment of diabetic foot infections. The other one is the guideline on skin and soft tissue infections. And one of the diabetic foot was published in 2012, and the skin and soft tissue was published in 2014. So these are still fairly recent. Some structural components related to the type of infection that you need to remember back to your anatomy days would include really going over the depth at which each of these infections would be classified as. Erysipelas is typically defined as including just this kind of superficial layer of skin, while cellulitis goes a little bit deeper. Okay? And necrotizing fasciitis is in the name, right? It goes all the way down to the deep fascia. Okay? And so that's really going into three of the main types of non-purulent infections. And then when you get to your purulent infections, they can also invade into the subcutaneous tissues sometimes as well. Myositis, we're not going to be talking about for the purposes of this lecture, but that's actually an infection of the muscle tissue, and that's also fairly, caused by similar organisms, usually, but this is also kind of more seen in tropical areas. All right. So impetigo. This is a picture of kind of a bullous impetigo where they actually have some bullae forming. Impetigo can be flat or bullous, bullae-like. I don't know how to say that. Bullous-ish? I don't know how to say that. But anyway, it can have these bullae, basically. But it also could be flat and just crusted. How many of you guys have seen probably a child with this type of infection? Yeah, I have a couple people raising their hands. It's fairly common, especially among young children. They like to spread it to each other too, so we'll get to that in a second. So it's a superficial infection of exposed areas, so usually it's not going to be on the trunk area, it's more going to be on your extremities usually, and your face. It's mostly common in children, especially in those younger years, between 2 and 5 years old, and it's also common during hot, humid weather. So in Florida, that would be year-round, but up north, they're going to see more incidents in the summertime. Okay? Minor trauma allows for the portal of entry. So imagine your integumentary system as kind of that big barrier here, right? So our skin is a huge barrier. It's part of our innate immune system. And if you have a break in that barrier, it's going to be an easy way for organisms to decide, hey, I want to make a new home here, and I'm going to go on the inside, right? And so that's really how these organisms end up causing the infection. So it could be a super minor scratch. Imagine children playing on the playground and they scratch themselves with a stick. If they already have that strep on their skin and they're scratching themselves with that stick, it's just like an inoculation, right? It's inoculating them with that organism. And it can rapidly spread through close contact. So siblings and young children in daycare centers or schools are especially susceptible to being able to spread this, okay? They like to play with each other and share toys and stuff like that, and that's definitely a way that these germs can spread. The presentation, often it's pruritus, so the child or could be an adult, adults can get this as well. They can present with itching, and it's like an itchy area. You can have some regional lymph node enlargement, but that's usually less common. You could present with weakness and a mild fever, but generally I don't see super high fevers in these cases. Children can get fevers with really minor things, and so I would say this is probably more in a child to be presenting with a fever. The common organisms are actually Staph aureus and or strep, and it would be beta hemolytic strep. So usually it's going to be methicillin susceptible Staph aureus when we're looking at antibiotic treatment options. Those are things that you should be thinking about. A gram stain and culture of the pus or exudates from the skin lesions is recommended to identify whether or not it's strep or staph, but I would say this is not usually done clinically, just because usually the physician will kind of guesstimate what the organism is and send the patient out on their way. I would say that this would maybe determine if it's just strep causing it or staph causing it, and that would be the main reason to do a gram stain or culture on this. But I don't see this done in clinical practice regularly. And the infection may spontaneously resolve. The duration of treatment of the antibiotics, if you're going to do oral antibiotics for this, would be 7 days. So how do we treat it? Well, for symptomatic relief, we can recommend soap and warm water to help with the crust removal. Empirically, with no penicillin allergy, you're going to use one of the anti-staphylococcal penicillins like dicloxacillin, or you could use cephalexin or Keflex, which again would have that staphylococcal activity, and both of these have streptococcal activity as well. So we're covering staph and strep for this infection. And notice these are oral agents, right? The presentation of impetigo would not warrant an IV treatment or any parenteral. It's not that severe of an infection, okay? It's not, and if the patient is presenting with a severe infection, it's probably not just impetigo, okay? If you do culture it and it just grows strep species, go ahead and use penicillin. Penicillin is the drug of choice for that. That way you're using the most narrow spectrum activity as possible. With a penicillin allergy, you could use clindamycin or doxycycline or Bactrim. Now, I hope you guys are picking up on, what is the most common age group for impetigo? Children, 2 to 5. Now, do we normally recommend doxycycline in that age group? Okay, great. So we probably wouldn't recommend it if it was a young child, right? Doxycycline we would avoid in those cases. So we'd be stuck with clindamycin or Bactrim, but I don't really like using Bactrim against streptococcal infections typically. We'll go into a little bit more about that when we're talking about some of the literature later on with cellulitis. But you could use Bactrim. I probably would go with clindamycin with a penicillin allergy, just as my preference. Topical therapy would be indicated in patients with few lesions. Mupirocin ointment, you would do this 3 times a day, for 5 days. So it's actually a shorter duration. And again, these are going to be a little bit more milder cases that you're going to use the topical for. And oral therapy is definitely preferred in patients with numerous lesions or in outbreaks that affect several people, like in a childhood nursing, or not nursing home, childhood nursing home, that's funny, a daycare center. In a daycare center to kind of get rid of that outbreak as quickly as possible, to reduce the amount of transmission that happens in a daycare, oral therapy would be recommended in those scenarios. Okay, moving on to cellulitis. Cellulitis. The common organisms we're going to see in cellulitis include streptococci, and often it's group A strep, but it could be group B, C, F, or G. So we're going with a whole bunch of different types of streptococci. And it actually does include strep pyogenes, which, how many of you guys are familiar with strep pyogenes? A couple people here, right? So this is actually one of those very invasive types of species, right? Strep pyogenes can actually cause what we're going to get into later, which is a very severe infection of like necrotizing fasciitis. Strep pyogenes is also sometimes called the flesh-eating bacteria sometimes. They'll go, the media will report it as that. So strep pyogenes is not something to just eliminate as, okay, it's just strep, right? This can be a pretty severe infection with strep. MRSA, though, is an unusual cause of typical cellulitis, although there have been a lot of debates on whether or not we need to be including MRSA coverage when we're looking at empiric coverage here. So, most cultures for cellulitis are not useful unless it's a very severe disease. Then some physicians will choose to do cultures. Punch biopsy specimens, which would be how you would normally culture this, actually only yield an organism 20 to 30% of the cases. And it's not a benign thing. You actually do take a chunk of their skin when you're doing the punch biopsy. And so it's not really a painless procedure type thing. And so I don't normally see physicians doing punch biopsies, and it's not routinely recommended to do. So usually you're empirically treating cellulitis mostly the whole time. It arises again when you have a breach in the skin barrier, and often breaks in the skin are small and unapparent. So you might not even know that you have nicked your skin or gotten a cut, and that's actually where usually there's going to be a portal of entry. It also can occur if you have like a fungal infection on your lower extremities. I do see this a lot in patients that, like homeless patients and people that have poor hygiene. Their skin is usually not intact completely, and you can see that they do have like kind of a tinea infection going up their leg, and that is a very common presentation for me to see of homeless people presenting with cellulitis. And I know the portal of entry is because they have this ongoing fungal infection on their legs, and that's how they got the strep in there. It can present as an acute diffuse spreading of painful erythematous skin, and it does not have an underlying foci. So this is different than a cutaneous abscess that has kind of like a pocket of pus, right? Cellulitis doesn't have that. It's just in the skin, and there's no pus pocket. There's no underlying foci of infection. It's associated with local edema and redness as well as warmth. So that's usually going to be the patient's complaint when they present to the hospital, is their leg is warm and red, and it might be itchy, but usually they're going to say painful, and that's usually how they'll describe it. Erysipelas is usually going to be referring again to the infection that's limited to the upper dermis, and it can include the superficial lymphatics. So here is a chart that actually comes from the IDSA guidelines. I would suggest you to familiarize yourself with this chart because it's incredibly important to know all of these different treatment recommendations. This is actually encompassing the majority of the material that I'm going to be going over today. So this chart, if you have this committed to memory and understand what makes an infection mild, moderate, or severe, you're probably going to do very well in the cases. You're probably going to understand what I'm going to be asking you to know, okay? So highlight this if you want. So it's broken down into two different types of infections here. So it breaks it down into non-purulent infections or purulent infections, okay? So non-purulent infections include severe infections like necrotizing fasciitis, and then some of the less severe infections like cellulitis and erysipelas, okay? The purulent infections include some of the less severe infections like a furuncle, and then going into some of the more severe infections like a carbuncle, and then some severe abscesses also would be included in this. So you can see there's a number of different treatment options listed here. We're going to go into those in detail. So treatment again for the non-purulent SSTI for cellulitis. For a mild infection, you would be using an oral antibiotic. And again, we're usually going to be targeting Streptococci species as our main target here. Some clinicians will want to cover for MSSA though, and the evidence for this is weak, but the guidelines do support you to cover MSSA if you feel like that is causing the infection. So the guidelines kind of don't really necessarily say you have to cover for MSSA, but they do state that some clinicians can cover for MSSA based on their clinical judgments. Duration of therapy is 5 days. So these are short durations of therapy. And you can extend the duration of therapy in a patient-specific manner, right, if the patient has not resolved the infection by the end of the therapy duration. You do need to cover for MRSA in very specific situations, which would include patients with cellulitis associated with a penetrating trauma, evidence of MRSA infection elsewhere, nasal colonization of MRSA, which this is debatable. Some people do not believe that this should be a risk factor for it, but currently in the guidelines it does state that this is a risk factor for it. Patients that have a history of injection drug use, and it would be a recent history of injection drug use, and then patients with SIRS, but these are actually going to be classified as severe, so you're covering for MRSA when you're doing severe coverage anyway. So that's kind of redundant in the guidelines. But for the moderate treatment options, you actually do start with an IV agent. And so you can use a lot of the same drugs. So we're going to use an anti-staphylococcal penicillin here, an anti-staphylococcal cephalosporin here, and then you'll have the option of using ceftriaxone, but I don't recommend ceftriaxone in these scenarios because I don't really necessarily feel like we need that gram-negative coverage, and there's more collateral damage. So we'll go through some pros and cons of the various different treatment recommendations. So penicillin, you're really only getting that strep coverage. And so the main comment here is that there's no staph coverage here. I hope you realize that all the PO options are kind of inconvenient when it comes to our dosing frequency. So this would be something to stress to the patients about compliance. These are Q6-hour drugs, all of them, so there's not one benefit over the other one here. For penicillin allergic patients, I would recommend clindamycin, and this is how I do it in my practice. I do recommend clindamycin for those patients. Unfortunately, you do have the risk of C. diff, so there is more collateral damage here. But I feel comfortable treating with this drug, and I know that I feel safe using this as an alternative. Anti-staphylococcal penicillin, like dicloxacillin or nafcillin, or oxacillin as well, if we're looking at a different IV. They have good staph coverage as well as good strep coverage, so that's something that we would be thinking about as far as the coverage there. But the same goes with our anti-staphylococcal cephalosporins, like cefazolin and cephalexin. They do cover MSSA as well as strep fairly well. And then ceftriaxone is good for strep coverage. I would say okay for staph coverage. It's not my favorite staph drug. And there is more collateral damage associated with it. The reason why I feel like clinicians like this option is it's a once daily drug, so it's easy. But I don't prefer this and I don't recommend it. In the case scenario, if I'm involved in the treatment decision, this is not what I'm going to recommend. But it is definitely an option listed in the guidelines as one of the treatment options that you can go with. All right, so that was mild and moderate. Now we're going to be talking about severe non-purulent infections, which would include our necrotizing skin infections, okay? Necrotizing soft tissue infections, these are the scary types of infections that are very rapidly developing. I would say this and meningitis are the big things that we fear as far as an infection presenting to the ER, because these things can progress very rapidly and patients can have high mortality and morbidity if we don't recognize the signs and symptoms of these things quickly on presentation. The one that we classically call is necrotizing fasciitis, and usually it's caused by strep pyogenes in greater than half of the cases, okay? It can also be caused by Staph aureus though, so we can actually get a MRSA necrotizing fasciitis. So probably going to be needing MRSA coverage. I would hope you guys see that there. Also Vibrio vulnifericus, this is important for those of us in Florida and anyone that practices around the Gulf, and I'll talk about that specifically. I have a slide dedicated to that because I do have personal experience with that. Aeromonas hydrophilia is more with freshwater. There's a freshwater association, not the saltwater. And I've never seen an infection caused by that personally in my practice, but other places that have a lot of freshwater lakes and such, they might see these types of infections a lot more common. And then you can see anaerobic and aerobic or mixed streptococci infections like Peptostreptococcus. Okay? Clostridial myonecrosis, which is slightly different than the necrotizing fasciitis in that it's actually going into the muscle tissue as well, would include gas gangrene, which is caused by Clostridium perfringens. And so usually the physician is going to see some sort of bubbling and such underneath the skin, and it's going to lead them to think, wow, this is a gas gangrene. And so that's usually caused by Clostridium perfringens. And the gram stain of this is going to show a large gram-positive or gram-variable rod at the site of infection. So for you guys to remember that, that's our Clostridia, right? So it's a large gram-positive organism. Fournier's gangrene is a necrotizing infection, but specific to the genitals. So it involves the scrotum or penis or vulva. And this is also deadly. So it's not, I know it sounds like it's a silly infection there, but it's a very severe infection. And it is very traumatic for patients to go through. Most cases are caused by mixed aerobic and anaerobic flora. And so these are polymicrobial. So I hope you imagine that we're going to need very broad spectrum agents for this. So this is not the time, any time somebody presents with this type of infection, this is not the time to be going narrow spectrum with your choices, okay? I hope you guys see on this list of all the different organisms that can cause a necrotizing infection that we're going to need to really cover for a lot of different things, okay? The mainstay of treatment for these necrotizing infection is actually not pharmaceuticals, it's actually surgical. So a surgical consultation is really going to make or break it for your patient. So you have to get the surgeon in there, like they need to go down to the ER to see this patient because they should probably be evaluating to take this patient to the OR within a couple hours of their presentation. Because it is a rapidly spreading infection, it's considered a surgical emergency. And so they do need to be consulted and involved in the patient's care, and they should be taken to the OR as quickly as they can. And empiric treatment would definitely be covering all these polymicrobial potential causes. And so our empiric treatment options are going to include a MRSA coverage. So you could use vancomycin, linezolid, or daptomycin. These all would cover MRSA, and these all get to the skin fairly well. So these are all potential treatment options for your MRSA coverage. But in addition to your MRSA coverage, you're also going to need to be covering for broad aerobic and anaerobic coverage, okay? So this is going to include either one or two additional agents, okay? So we're already thinking we're covering with a lot of different drugs. So your options could include addition of piperacillin tazobactam. So that's a one-drug option that you would add to your MRSA coverage. Or you could use a carbapenem. Or you could use ceftriaxone plus metronidazole because ceftriaxone does not have that anaerobic coverage. So we would need to add metronidazole to get that anaerobic coverage. Or you could use a fluoroquinolone plus metronidazole. I would not necessarily recommend this as my first choice. The only time I would get stuck doing this is if someone had a number of different drug allergies, and that's when I'm going to have to use something like this. But I've never encountered a patient where I couldn't use a carbapenem instead. So thankfully, because I would use that over a quinolone for sure. And you see here the guidelines actually recommend my nemesis Vosin, which is vancomycin Zosyn. And I say it as my nemesis jokingly because a lot of patients end up getting Vosin or vancomycin Zosyn in the ER and they don't need it. This is a case example of when they do need it. They do need this broad spectrum coverage and they do need it empirically. So this is an example where this actually is indicated. We have a couple different defined monomicrobial infections. If you were to get a culture of this infection and figure out that it is a monomicrobial infection, meaning it's one specific organism, you would want to use targeted therapy to target those organisms. And I would change to this as soon as I know the cause of the infection. And so for strep pyogenes, I would recommend penicillin plus clindamycin. The same goes with gas gangrene with Clostridial species. I would use penicillin plus clindamycin. For Vibrio, I would use doxycycline plus either ceftazidime or cefoxime. And for erymonis, I would use doxycycline plus ciprofloxacin. For polymicrobial, you are stuck with your friend Vosin, right? Vancomycin, Zosyn. And that's usually going to be continued for the entire treatment, especially if it's polymicrobial. You're most likely going to continue this broad spectrum coverage for the entire time. Now, for the duration of treatment, it's actually variable. There's not a defined duration of treatment for this, because oftentimes these patients are going to have to go back and forth to the OR for debridement or amputations, depending on the severity of infection. So if the infection was starting from their foot and they had to get their foot amputated, sometimes they have to go back to the OR and get the rest of their leg amputated, or a below-the-knee amputation and things like that. That's how severe these infections are. And so you do see limb amputations in these types of infections, and further debridement sometimes is necessary, even if they have clean margins on their initial OR trip. So usually you would want to recommend to discontinue the antibiotics if the patient is completely better, basically, and has no fever for 48 to 72 hours. So this is not the type of infection that I'm going to be asking the physician to stop antibiotics as quickly as possible. This is the type of infection that I'm like, all right, I want you to continue as long as it takes until you get better, because these are very severe infections. So let's think about these regimens. When I was talking about a monomicrobial infection, I'm thinking one bug. If we know the bug, why are we using 2 drugs? And all of them have that in there, right? We're kind of using it for synergy in some cases. Some cases it's for toxin inhibition. But also, oftentimes susceptibilities are hard to do on a lot of these organisms. That actually we're not able to do susceptibilities on some of these. So they're not as routine as a lot of the other types of bugs that we're seeing. For strep pyogenes, you're able to usually do your susceptibilities on that. But strep pyogenes aside, we don't typically perform susceptibilities on anaerobic agents, or anaerobic organisms, sorry. So for Clostridium, we're guessing, right? So we don't necessarily know the susceptibility there. For group A strep, clindamycin is useful to suppress streptococci toxin, right? Because we know it's working on the protein synthesis. So if you stop that protein synthesis, hopefully you're going to stop that toxin production, right? And it also has some cytokine inhibition as well. It helps with some of that inflammation process. Penicillin is added to this regimen. It sounds like I'm making the case for using just clindamycin, right? But we add penicillin to this regimen because there's a potential of resistance in your group A streptococci to clindamycin. Now, in the United States and the epidemiologic studies that I could find, we saw about a less than 5% chance of resistance to clindamycin in our streptococci species. However, in Spain, there was a study recently that showed up to 18% of their strep species were resistant to clindamycin. And in Germany, they saw 8% resistant clindamycin. So I would say we know that they are capable of being resistant to clindamycin, and that some places have higher resistance rates than others. And as I've alluded to, these are very severe infections, so I don't take my chances with that. And so that's when we're going to be adding penicillin to these regimens. We're doing it for that reason, is that just in case there's clindamycin resistance. For Clostridium species, because about 5% of Perfringes is also clindamycin resistance, we do use penicillin and clindamycin for that as well. For Vibrio vulnifericus, go to the next slide. This is a very fatal type of infection. And during my PGY2 ID residency, I did encounter this infection actually twice. One time the patient did present with these bullae on their legs, or actually they only had like a couple when they first presented to the ER. They had like a few of them. But 16 hours later, they were in the ICU and they were completely covered with them. After multiple amputations and unfortunately it was unsuccessful, and the patient did pass away. And so I stress this just because you will see this if you are practicing on the Gulf Coast of Florida or anywhere on the Gulf, even if you're practicing in like Houston, because Vibrio vernifericus is actually just in the water. It grows in the water, and so in salt water. And so you can see this just from a minor scratch walking out there on the beach. And so this is something that I want you guys to be aware of as a potential life-threatening infection. Even though we diagnosed it promptly, even if you start antibiotics and take them to the OR and you clean up everything, even with that, the case fatality is at 30 to 40%. And if you don't diagnose this, the case fatality is 100%. So it's not something that self-resolves, and it is a serious infection. So who is at risk for Vibrio? Well, definitely patients with immunocompromising conditions, but especially patients with alcoholic liver disease. These patients are found to be much more susceptible to Vibrio infections. And there's a number of different reasons that are beyond the scope of this class of why patients with liver disease are more at risk for Vibrio, but just knowing that risk factor is important for you to know when a patient does present with bullae, right? Then you're going to need to look into some of their social history. A source of Vibrio would be exposure to warm seawater, but additionally, it can happen anywhere, especially in the Maryland area where they have a lot of raw oysters. So the portal of entry also could be from eating oysters. You're not going to see Dr. Worley at any raw oyster bar because of this reason. I used to eat raw oysters until I saw this patient, and then I will never do it again. Sad day, because I liked them. Yeah, I really did like them, but I can't do it. I can't take that risk. So oyster industry is now calling me up right now. I'm just kidding. But the raw oysters is another portal of entry. So it could be, so you would want to maybe ask that kind of a history, and that's usually what the physician is going to do. And usually if it's an oyster type presentation, they also are ill in their stomach. So they do present a little bit different than the patients that are presenting with the skin as the portal of entry. But if it's already at that severe point, they still have the skin bullae as well. So they still do kind of look the same at the end of the day. Within 24 hours of symptom onset, so that's one day, greater than 50% of patients get this characteristic skin lesion of severe cellulitis with this, it looks like this. And other symptoms would include fever, nausea, vomiting, diarrhea, and then over half of them have changes in mental status. This is how severe it is they're not even able to really communicate as much anymore. And 33% are actually in septic shock at the time they come to the hospital. And so that's how severe. So if you have a relative that has this on their leg, take them to the ER, right? Or even not a relative, just a random person or a patient. You should send them to the ER if they have this on their leg and they're like, what do I do with this? Go to the ER, right? And because the infection spreads so quick, the bacterial load is often really high. So that's really the reason why we're using 2 of these agents, and we're doing the high dosing for these agents as well, okay? And so they, using a 3rd generation cephalosporin as well as using a tetracycline appear to be synergistic against Vibrio. So that's really why we're using this, was we have a huge inoculum that we're having to deal with to get rid of, to clear. And so we want to have as much help as possible, and having synergy can help us reduce that load, that bacterial load. All right, moving on to a little bit more lighter notes, because we're going into some less severe infections. We're on the other side of the treatment algorithm now. So that was in your non-purulent infections, and now we're going into our purulent infections. So we're going to start off with follicular infections. And it's an infection down here in the hair follicle. So kind of sounds like its name. So it's an inflammation of the hair follicle that's caused by physical injury, so could happen from shaving, right? Chemical irritation or infection. Furuncles is actually a walled off mass of purulent material arising from the hair follicle. So it's again going to be surrounding that hair follicle, and you're going to start seeing some pus there. It's also called a boil. So that's what some people will call it, as a boil. It's a furuncle. It's a fancy term for it. A carbuncle is when a bunch of adjacent furuncles coalesce to form one big single inflamed area. And common organisms to cause this is our best friend Staph aureus, right? So we're familiar with treatment options for Staph aureus, or you should be by this point. Folliculitis, it's going to look like this. So as you can imagine, this is fairly benign. I know all of us have had folliculitis at some point in our lives, right? You would have really perfect skin if you never had folliculitis. And I would be like, what do you do? What kind of cream are you using? You could sell that as a pharmacist, right? All right. So with folliculitis, as I said, it's pretty superficial in nature, and it does have some pus present at the epidermis, but it does not extend down. This is the main point that differentiates it between going into your furuncles and going into your carbuncles and then going into cutaneous abscess. So it's really, really superficial. It's just right there at that hair follicle. It doesn't go down. It heals by itself over several days, as I'm sure all of us probably are familiar with. It does go away, and generally treatment is not needed. One thing that you can do is apply a warm compress to try and get those pores to open up and get rid of the pus, and then it goes away. Okay? So this is something that you can definitely help patients with. If they're coming to you and they're like, what is this on my arm? And you're like, that's just folliculitis. Go ahead and put a warm compress on it, and it'll go away. And that's what I would recommend for them. One type of folliculitis is also called hot tub folliculitis. So if they say they were just in a hot tub, it means it was probably not chlorinated very well. So they should probably go to the store and get some chlorine or bromine. And Pseudomonas aeruginosa is usually the culprit for that. But again, when I'm talking about folliculitis, it is a superficial infection. So it is not going deep in there. So if they were having hot tub folliculitis, again, this is going to be a self-resolving thing. We're not going to start them on an anti-pseudomonal penicillin, right? This is something that is a very simple type of infection that will be self-resolving. The main counseling point would be for them to chlorinate their pool better. That would be what you would suggest if they presented with hot tub folliculitis. I would suggest to make sure that they were swimming in adequately cleaned water. Now we're going to go into the actual treatment when we actually do need to do some treatment, which, again, as I said, we're on the other side of the treatment algorithm when we're going over purulent infections, boils, or furuncles. The common organism is Staph aureus. I hope you can see slight difference between folliculitis and a furuncle. You can see that this extended area around here is also red. It's not just around right here. You can see it's slightly raised. And so there's definitely more going on underneath the skin than just a simple folliculitis, right? For folliculitis, it shouldn't be this big and red around it, okay? A carbuncle, this is a picture of it. This is actually, I think, on someone's hand. But normally when I'm thinking carbuncle, I'm thinking the back of their neck. But this is a bunch of those furuncles have now coalesced, and so this skin does not look very intact either. So the presentation of these, for a furuncle, it's suppurative and it extends through the dermis into the subcutaneous tissue. So again, you're going to see a little bit more tissue involvement there, where a small abscess forms. It's not a large cutaneous abscess, but it is a little baby abscess, right? It's broad, it's swollen, it's erythematous, as I mentioned on that slide where I'm showing the redness around it, and it's painful. It's a painful follicular mass, right? Because there's still around a hair follicle there. And carbuncles, again, are going to be a bunch of furuncles that have coalesced together. And these commonly develop on the back of the neck, and I see this more in my diabetic patients. They just seem more prone to getting skin infections, and I see it more in those patients, especially in the back of the neck. What's our treatment? For small furuncles, we actually can treat it just like a folliculitis with a warm compress and drainage of the pus, right? If you have a larger furuncle or carbuncle, it would be necessary to start with incision and drainage so that you're able to get out all of that pus that's in there. And systemic antibiotics are usually not necessary, but I would say that most of the time with carbuncles, it's severe enough to warrant systemic antibiotics. Just the things that I've seen. Carbuncles usually present a little bit more severe, and so I would say they usually would classify under a moderate infection, but it is possible to have carbuncle that presents very mildly. Okay, it just could be a bunch of furuncles coalesced together, and it's not really causing any symptoms really, except for pain locally. For moderate infections, though, you do have some systemic signs of an infection. So you would potentially maybe get a fever, you would start feeling ill, you would get malaise, kind of that generalized yuck, I don't feel good. So you would start feeling some of those symptoms, and that would make me think, okay, I want to treat this systemically instead of just incision and drainage. I also want to give some antibiotics. But for these moderate infections, you don't need intravenous antibiotics. You can just incision and drainage and send them out with PO antibiotics. So you could still do oral antibiotics in these cases. And so I would start with something like Bactrim or dicloxacillin or cephalexin. Again, I'm targeting Staph aureus, right? Treatment of severe infection of a furuncle carbuncle would include an intravenous agent. And so you are going to be going with an anti-staphylococcal drug, and you're going to be covering for MRSA in these cases. Severe infection is defined in the guidelines as the failed of incision and drainage plus PO antibiotics, or those with severe signs of systemic infection, which would include your SIRS criteria, right? So we have a high temperature here, a high heart rate, respiratory rate is increased, or leukocytosis, or alternatively leukopenia. Or if a patient is immunocompromised, I'm going to automatically classify them as severe because they're more at risk for the infection to spread and to spread quickly because they don't have that immune system to keep those bacteria in check. And you would always cover for MRSA empirically in these scenarios of severe infection. I hope you guys realize that some of these options for mild or moderate infection do not cover MRSA. Which one of these three options covers MRSA? Bactrim, right? So we have one of our options for moderate infection that does cover MRSA. Otherwise, dicloxacillin and cephalexin do not cover MRSA. We can't do the same thing with severe infections. We do need to cover MRSA in severe infections, okay? All right, abscesses. I guess I probably want to take a quick break here because it is 11 o'clock. So we're going to start back right at 11:10. Okay? Get back to the fun stuff, the nitty-gritty. We're going to start with talking about abscesses. Can I get you guys ready? All right. I know it's exciting. This is a very exciting topic. And it's right before lunch. You're welcome. Yeah, it's a diet day today, huh? All right, so abscesses. As you can see here by this little cartoon-like picture, it's really as simple as just it's an accumulation of bacteria and pus underneath the skin, and it includes the subcutaneous tissues here, okay? All right, usually your cutaneous abscesses are polymicrobial or Staph aureus, and MRSA is the most common cause. Yikes, we already know that's going to be a problem, right? Because a lot of our oral agents do not cover MRSA. So you can already predict that there might be some difficulties in picking an easy, simple antimicrobial option to treat this. But we'll always need to be covering for MRSA. It's a collection of pus within the dermis and the deeper skin tissues. Okay? And the clinical signs is just a painful, tender, fluctuant red nodule. Okay? It again is on this side of the guidelines where we're going over the purulent infections. And oh, I want to note, just for those of you guys who might not know the shorthand here, IND is the incision and drainage. That's what's listed here. And CNS is your cultures and susceptibilities, right? So So we already can picture, we're actually recommended to do culture and susceptibilities on a lot of these types of infections that present. All right, so the main treatment of cutaneous abscess always starts with incision and drainage, and this is definitely an important feature for being able to, get a nice culture result, because we can actually culture that drainage there. And so it's not a superficial swab anymore. We're actually getting a nice pus to be able to get what is actually growing underneath the skin. And after you get all the pus out through an evacuation and probing of the cavity to break up any loculated areas, you can pack this with gauze or packing material, or suture it closed, but most people don't choose to suture it closed because it's just common practice that they don't usually suture it closed. I could explain some anaerobic fears of things, but we don't have to get into that. Just know that usually suturing is not done. Usually they do packing for this type of infection. Gram stain and culture, as well as systemic antibiotics, are rarely necessary in the mild infections, which is usually what we were going to see unless the patient lets it go for a long time, right? So the exceptions to the mild infection part, or the not using systemic antibiotics, would be any patient that presents with extensive surrounding cellulitis, so a bunch of redness surrounding that abscess. That's an indicator that it's spreading. And so I don't necessarily trust that removal of the pus there is really going to get rid of all of it. If you have cutaneous gangrene, that's definitely an indication that it's more severe. There's something else going on there. It's not just a simple abscess, right? And immunocompromised status would always indicate that you do need to be a little bit more cautious in these patients and be treating a little bit more aggressively. Signs of systemic illness, like a high fever, would be indicative that it's probably going to fall under a moderate or severe infection rather than a mild infection. And if you have multiple abscesses, we're usually going to be treating not just with incision and drainage, but we're also going to be adding in a PO antibiotic at least. And depending on the severity, we might have to use intravenous. Extremities of age, and this is usually a risk factor for a lot of things. So in the very young patients and in the very old patients, we are more concerned about their risk factors for potentially progressing into more severe disease. So we're usually going to use PO antibiotics at least in those patients, even if they present with a more milder disease, just because they're at a higher risk of potential complications, okay? And then if you have a lack of response to incision and drainage alone, then we're going to be initiating some sort of antibiotic, whether or not it's oral or IV. Usually we're going to go to the IV agents actually for that, at least for a first dose. This is an FYI slide. As a pharmacist, you're not going to be performing incision and drainage, but I wanted this to show you guys what they're doing. My students on rotation, they think it's so fun to see the physicians actually go in and drain abscesses. It's kind of cool to see, as long as you're not one of those people that gets super queasy. But they do make an incision along an existing skin tension line, which I'm not going to ask you to know any of that stuff. So again, this is FYI. And then as they extend the incision, this little circle is supposed to be the pus pocket, right? And they go in and they dissect and they kind of get out anything that comes out of that pus cavity. And then they put packing material in. And this is usually going to look like a long strip. It's almost looking like it's a tape strip, but it's not sticky. And this is actually important because every time you take out the packing material a little bit, it helps debride out some of the rest of the pus that might accumulate after you've already drained out the majority of the pus. So it's kind of just slowly debriding it as you pull out the packing material. So that actually has a therapeutic reason for being in there as well. Treatment of cutaneous abscesses, if we're going to need to use treatment, like if it's not a mild infection that just needs IND, we would be initiating an antibiotic, which usually will be needing to cover for MRSA. So I know that the guidelines actually have an option of using cephalexin or dicloxacillin, but these do not cover MRSA. In my practice, I usually want to cover MRSA. These are listed as potential options. I would only probably use these in a place where you don't have as much MRSA in your area. But I wanted to note that this is a potential option. According to the guidelines, they do feel like there's evidence to support the use of these agents empirically. I personally don't choose these as my empiric option in my practice, Okay. In my practice, I'm going to go usually with Bactrim. That's usually my mainstay for treating of a mild infection, because I feel like the C. diff risk is less with Bactrim than it is with clindamycin. But I could also use clindamycin because it does have some MRSA coverage depending on your area. So you'd want to look at your antibiogram to look at your MRSA and how susceptible they are to Bactrim as well as clindamycin. Okay. And doxycycline, I don't typically use this, and there's limited clinical experience with using this, but again, this is also listed as a potential oral option in the guideline, and so I would probably only reserve this for patients that can't take the other options. Okay. For severe infections, the mainstay of treatment, at least where I have worked so far, has been vancomycin. This has been the preferred drug of choice really for MRSA SSTIs. It has great tissue penetration. We know it gets to the site infection rate, and it does cover MRSA. We're not as worried about MRSA resistance to vancomycin, right? And it's a lot cheaper than daptomycin. Daptomycin is kind of almost prohibitively very expensive. Each vial costs around $300. So imagine a treatment, especially if you are a heavier person where you might need 2 vials to cover you, that's $600. That's just drug acquisition costs. That's not actually what you charge the patient, which is usually upwards of $1,000 per day, okay? So that's usually going to be something that we're not going to go with, right? Linezolid now is less expensive, so this is potentially a treatment option that people can be gearing more towards. And again, it's going to depend on your facility and whether or not this is highly restricted by an antimicrobial stewardship program or by an infectious disease physician. My personal opinion is that I don't believe we should be as heavily restricting linezolid as we have in the past, because I do feel like this is a great option to reduce the nephrotoxicity rates we do see with vancomycin, because linezolid doesn't cause that. Okay. And then we also have an option of ceftaroline. When this drug first came out, I thought we were going to use it a lot more than we end up using. I'm surprised that clinically a lot of places are actually not really utilizing ceftriaxone as an option, and I'm actually not sure what made everyone kind of steer away from this. It might be because it does have some gram-negative coverage that you just don't need, and so that might be why a lot of stewardship programs decided not to really include this on their formulary, but I don't really understand why this became kind of a let's not use it drug, besides the fact that we were trying to reserve, I guess, the new generation of cephalosporins. But this would be probably the type of infection that they would be great at, right? So, you know, it is what it is, but ceftaroline is definitely still one of those first-line potential options there. It's IV only, though, as most of these agents are, except for linezolid, and there's no oral equivalent, okay? For severe infection, which is defined as a failed IND plus PO antibiotics, or those with systemic signs of infection, and so you're going to have to use one of these parenteral agents with that, okay? All right. So there was a study that came out in 2015, so somewhat recently, that actually kind of changed my mind about some of the practice things that I've done. So clindamycin versus trimethoprim sulfamethoxazole for uncomplicated skin infections. This was in outpatients only, so this wasn't necessarily in the patient population that I'm most familiar with. And they looked at clindamycin, a 300 milligrams PO TID versus Bactrim 1 double-strength tablet, orally BID for 10 days. And Staph aureus actually was in a significant amount of these cultures, as one would probably expect, right? And the majority of those staphs were actually MRSA in this case. And the cure rates did not differ significantly between the two treatment groups, even in the subgroups with patients with cellulitis. When I'm thinking cellulitis, I'm normally thinking you need adequate streptococcal coverage, right? And I don't consider Bactrim adequate streptococcal coverage. So this was a big confusing thing for me. Bactrim previously has been considered a poor empiric choice for the treatment of cellulitis because of its historical treatment failures in numerous studies back in the 1970s and 80s. So this is like old school data that we're looking at. So we've always been taught Bactrim's not really your good streptococcal drug because we saw so many treatment failures when we were using it for pharyngitis. which is caused by strep, right? So the current topic of debate is whether or not we can use Bactrim for an SSTI, despite this strep issue. And I would say, I don't know. If I see some sort of abscess formation, I'm thinking it's more caused by staph and less caused by strep. So if I see any kind of pus in the infection, I feel a lot more comfortable using Bactrim because I'm most likely suspecting that this is Staph aureus and not strep species, okay? So that goes into my thought process on whether or not I feel comfortable using Bactrim. But this story kind of threw me for a loop. This article. It was a great study. I felt like it had a lot of strengths to it. And so this made me, and I think a lot of other infectious disease people go, I wonder what's up with that. All right. So all that aside, now we're going to go talk about animal bite wounds.
Dr. Worley?
Sure, go ahead.
I have a question. So the purulent dead infections that we are doing, they mostly deals with MSS or MRSA. So why we are taking a comparison for the strep?
In most of the, what type of infection?
Okay, I got it.
Oh, okay.
So
okay, we got it. Okay. All right, good. Because I didn't hear the whole question. All right. If you do have a question, please feel free. All right. Animal bite wounds. This poor guy, look at his hand. Animal bite wounds can present in a number of different ways. Some people can present as they were mauled by an animal, like they have tons of penetrating traumatic wounds. And other people can present with just a simple, like the cat bit my pinky, or the cat bit my hand. Believe it or not, cat bites are horrible because they have really, really dirty mouths, okay? And it can become this quickly. You don't treat it. This is not even the leg anymore, really. All right. So, animal bite wounds. How do we treat these? Usually they're polymicrobial. Imagine your animal's mouth. He's not, or she's not, really going to be gargling with Listerine regularly, right? So they tend to have organisms living there as part of their normal oral flora, right? Their normal oral flora, unfortunately, contains pathogenic and virulent organisms like Pasteurella not going to say that right now. Moraxella, you guys should be familiar with that from your little MCAT, your upper respiratories, right? Otitis media. Neisseria species, Streptococci, Staphylococci, Fusobacterium, Bacteroides, not going to do that one today. I'm so sorry today, my pronunciation is off. Prevotella, as well as that other organism. Usually I can say these things. I usually practice them before presenting, and I forgot to practice those bugs today, so I apologize. Mouth and skin flora is what we're covering for. Not your mouth's flora, but the animal's mouth's flora. But your skin flora, right? Because it's penetrating your skin, okay? So we're not swabbing the cat to see what they had on their skin, right? That'd be funny, though. The cat already bit someone, so I don't know. I wouldn't go near that cat. All right. So treatment will need to be active against both aerobic and anaerobic bacteria. As you can see, this polymicrobial mix of organisms includes both anaerobes and aerobes, okay? Dog bites are the most common, but cat bites tend to be more severe, in my experience. So the bite pattern really does usually determine the infection type. So dog bites are associated more with the crush injury because their mouths are usually bigger. So I'm saying this without regard to Chihuahuas who have very small bites, right? So in a normal dog bite, it's mostly going to be a crush injury, and it's usually not going to have a nice little inoculating little tooth that creates an anaerobic environment. Usually it's going to just be kind of your simple, you wash it out, hopefully it didn't break any bones, but that's usually what you're worried about with dog infections. And so it can be kind of that tissue that's injured from the actual bite itself that's more of an issue. Whereas cat bites are the worst, right? So cat bites, you could tell I'm a dog person, sorry. I'm a dog person. Cat's bad. But cats are associated with, their bites can cause septic arthritis, meaning you have an infection in your joint from this. So even a little bite on your finger, if the cat thinks it's funny, I have seen this turn into septic arthritis, where we needed intravenous antibiotics, believe it or not, from a cat bite on your finger. Don't let them mess with your hands, all right? It can cause osteomyelitis, meaning it goes all the way into the bone, and I've definitely seen this too, from cat bites, not from dog bites, cat bites. And it also can cause abscess formation, okay? So don't let the cat bite you, okay? Also, when we're talking about animal bite wounds, we need to consider feral animals, okay? So hopefully everyone's pets have had their rabies vaccine and you're not really concerned with that. But again, if you have a feral animal or a wild animal, you do need to consider rabies. And so this is something that your local health department will help you with as far as having an algorithm and being able to initiate the rabies vaccine series, okay? Because unlike other vaccines that we have out there, the rabies vaccine is actually given after you've experienced the bite. Has anyone here ever heard of the rabies vaccine? Right? Okay. So it's multiple doses, and you actually get it after your exposure. But because rabies has a longer time where it incubates before it gets into your CNS, you can actually prevent it from actually getting to your CNS, right? Because rabies is a virus that it's uniformly deadly, right? If you get rabies and you actually are infected with rabies, you're going to die. It's 100% fatality rate, right? So in these cases, that's why the health department does have a lot of different algorithms that they use to determine if the patient does need to prophylactically get the rabies vaccine. And we also, depending on the bite, you could also use an immune globulin to protect for rabies as well, okay? And so usually your hospital pharmacy will have some of these doses actually kept. It'll depend on how big your health system is, whether or not they keep these in stock regularly, but I would say most of the places I've ever worked does have at least a couple doses of these things regularly in stock in your pharmacies, okay? So the post-exposure treatment would include wound irrigation as well as soap and iodine solution. And then the vaccine is a 4-injection vaccine, so you do it on day 0, 3, 7, and 14, okay? And then, as I said, sometimes it's indicated to use the immune globulin, and you will have to determine this based off of your local health department and what they are instructing, okay? So because they're able to monitor the scenario in the local wildlife to know how big of a risk it is for rabies, your hospital is not going around testing animals to see how likely they are to have rabies, right? That's something that the wildlife and parks departments and stuff like that, they do that, and they communicate with the health department how much rabies is in the area. And believe it or not, we have animals with rabies in the area, okay? When I was in Fort Myers, there actually was rabid chihuahuas. I'm not joking. I brought up chihuahua for a reason, because there was a rabid chihuahua, and that's really sad because they're so cute. But, you know, they have to then be put down, unfortunately. The dog was sick at that point, you know, that's how they figured out that this dog has rabies, actually. So tetanus is uncommon if we're looking at other bite wounds and stuff that we need to do, but with a bite wound, we're always worried about the dirt that could get into that as well. So tetanus comes from dirt, really, rusty things, dirty things. And so if you're creating a nice anaerobic environment where tetanus can grow, because tetanus is an anaerobic bug. Sorry, do I have a question back there? Okay. So tetanus is an anaerobic organism, and so with that, penetrating wounds are much more susceptible to potentially having tetanus in them. And so usually we're just going to instantly go ahead and give them their tetanus booster shot. As long as they haven't gotten it within the past 10 years, we're going to be initiating, and in some places you're going to be looking at 5 years depending on your algorithm of just giving a rebooster. And then you can also, depending on the severity of the infection, there's tetanus immune globulin, so that's usually not going to be used in the bite scenarios, but that's also potentially an option there. First line of treatment from an antibiotic standpoint for treating a bite wound, for an outpatient therapy, meaning there's probably not that much of a crush injury and there's not much tissue damage so much that you would need any sort of surgical help, you would definitely use, my first line choice would be Augmentin, right? So we're covering a lot of skin flora. We're definitely covering the bugs in the mouth with that. We're not necessarily covering for MRSA in this scenario, so if it ends up that it's MRSA, which could come from your skin, you would need to broaden the coverage, right? So the patient would probably not be getting better. But usually what's in the animal's mouth is susceptible to augmentin. Usually these organisms are not the super pan-resistant bugs that we're worried about. An alternative option could be doxycycline or penicillin BK, or dicloxazole. I meant to put or dicloxazole there. For a penicillin allergy, you could use trimethoprim sulfamethoxazole, but you would also need to be including anaerobic coverage with that, so you would have to add on either clindamycin or metronidazole in this scenario, okay? So if you have a penicillin allergy, you're going to have to add in anaerobic coverage to the Bactrim. That would be my mainstay. If I'm going to be adding in a bite wound treatment in a penicillin allergic patient, I'm going to use Bactrim, and most likely I'm going to add metronidazole in there, just because I don't really want to use clindamycin if I don't have to, because of the C. diff and collateral damage there. For parenteral therapy, so this is a more severe infection, we're going to be using our beta-lactam, beta-lactamase combination, which includes piperacillin tazobactam or ampicillin sulbactam. So again, ampicillin sulbactam, that's very similar to augmentin as far as antimicrobial coverage, right? Okay. So you could also use a second-generation cephalosporin with anaerobic coverage, depending on your formulary. Or you could use a carbapenem. I would not use a carbapenem in most scenarios. If the patient presented like super septic and kind of a mixed picture, maybe they're infected with something else and not just the bite wound, you could consider a carbapenem. But I wouldn't usually consider a carbapenem in these scenarios because it's usually unnecessary. That's usually overkill if we're looking at that. Okay? And you always need to cover for anaerobes. Irrigation and surgery is indicated in some scenarios, especially if the bite is severe. Or if it's something that you need to debride, like if there's something underneath the tissue. And the duration of treatment varies based off of the presentation and how severe the illness is, okay? Some of these you can treat with just 5 to 7 days. Others of them you're going to have to extend for a little bit more of a longer duration of treatment. Osteomyelitis. So this is an infection of the bone. And I have it, it's generally uncommon, but I end up seeing it a lot in the hospital because these patients often need to be hospitalized to get intravenous antibiotics. So I encounter it a lot in my practice, but it's overall, in the general population, it's uncommon to have osteomyelitis. Acute osteomyelitis and chronic osteomyelitis occur almost at the same percentages. Acute osteomyelitis is defined as the onset in several days to a week, whereas chronic osteomyelitis is something that is a slower, more insidious process, where maybe you have some sort of a cutaneous infection for a while and it kind of just lingers around and you don't get it treated, then it goes into osteo. We see this a lot in untreated diabetic foot infections, where patients are letting the infection go for too long, and then they get osteomyelitis in some of their toes and need amputations. So there's different classification as far as the different types of osteomyelitis that can occur. The first one would be contiguous spread. So it's going to be kind of that picture I presented with that soft tissue infection, then kind of going deeper and invading into the bone. And it's almost half of the infections are contiguous infections. Another type of infection would be a hematogenous spread, meaning there's an infection elsewhere in the body, and then the spread of that organism would then inoculate into the bones and cause the infection there in the bones. And this is less common. I don't typically run into that scenario. And also peripheral vascular disease can cause, you would have osteomyelitis, and usually it's going to be in your lower extremities. So even if you don't have diabetic foot, or maybe if you don't have diabetes, maybe you have peripheral vascular disease, and it's going to cause a similar type of presentation as your diabetic foot osteomyelitis infections, right? So you're going to have that decreased flow, just the same as you would have decreased venous flow with diabetes as well. If you have that microvascular damage, that's really going to cause you to have less lymphatic drainage, less ability to kind of clear out anything that starts to kind of pool there. And that's a really great place for bacteria to replicate, okay? If they're not cleaning it out, right? So this is more of an FYI. I don't need you guys to memorize this slide. This is more just for you guys to kind of understand that sometimes we can kind of guesstimate based off of the site that's involved of the infection as far as how it occurred. But this is not, you don't really need to know this for the treatment of these infections, but this is what the physician is going to be going through as far as, oh, how did they get this infection, okay? So for contiguously spread, if you're thinking on the femur, tibia, mandible, vascular insufficiency, as well as contiguous also would be feet and toes. And I would say these are the more common things I see in clinical practice, just because we do have a lot of untreated or unfortunately poorly managed diabetic patients. And that's when I'm usually seeing my osteomyelitis cases in those diabetic foot infections that are not treated, that are not managed, that then turn into osteomyelitis. And then we're seeing like foot amputation, toe amputations and stuff like that because of the infection. It's all the way in the bone. And if it's fully necrotic, you can't fix that, right? If the bone tissue is dead, your body can't regrow it like that. We're not lizards. That would be cool though. All right. So the treatment is really going to be organism specific. So hopefully you get a surgical culture. That's my main pet peeve, is when you take someone to surgery and you go and you debride it and you get out all that gross tissue, and then they forget to send surgical cultures, so you're stuck on Vosin. That has happened to me a number of times recently, unfortunately. But the organisms are usually going to be your gram-positive bugs. So Staph aureus or coagulase negative staph, streptococcus or enterococcus. You can see gram-negatives, and I see this more in my diabetic patients because the diabetic foot infections can then be gram-negative organisms. And you really have to get culture susceptibility because you want to get targeted therapy there. And unfortunately, we're usually having to use broad-spectrum agents in these infections. And the antibiotics are usually given at very high doses so that you can get adequate antimicrobial concentrations in the bone and joint if it's a septic arthritis, right? And so usually the serum to bone ratio is important to consider when we're picking an option for osteomyelitis. And the duration of therapy is usually 6 weeks. They say 4 to 6 weeks, and usually I see it done for 6 weeks, okay? And if you have MRSA, it's 8 weeks because treatment failures and relapses and recurrences occur if you do it less than 8 weeks, okay? So 8 weeks is what we do for MRSA. Imagine this is usually going to be intravenous antibiotics for 8 weeks. So that's why you end up seeing these people a lot. They just stick around for a long time in the hospital. All right, diabetic foot infections. This is a mild diabetic foot infection that I have here on the screen. They get much worse than this, such as this. Usually they're going to be polymicrobial. This patient clearly already had a severe infection and had a toe amputation. So this is probably their second or third type of severe infection, right? Believe it or not, these patients will present with really, really not intact skin, and you're wondering, how long has this happened? It takes weeks to get it this bad. It's not something that occurs overnight. And so this is why I stress diabetic foot care in patients. They need to check their feet, okay? Because you might not feel it. With the nerve damage that occurs from really high levels of blood sugar for long periods of time, you don't feel things anymore. So patients actually don't feel this injury. And I know it looks really kind of grotesque, right? There's a huge hole, there's a gaping wound here, but they actually don't feel it. So if you see these patients, they're just sitting in their chairs, super happy, smiling at you. They're like, why do I have to be in the hospital? And we're like, look at your foot. Right? But they don't feel it. So that's why I stress to all of my diabetic patients, they need to take care of their feet, because they might not feel that there's this huge injury on their foot. They might not be aware of it, right? Especially if it's underneath the foot. Then they can't even see it. So having somebody else help them and say, you know, I might have stepped on something earlier. Can you check my foot out? You know, or lift up your foot, look at it, right? But they might need help with this. So really trying to make sure this is a counseling point for all diabetic patients so that we don't get here, right? We don't want to be in this scenario where we're looking at this, right? But when we do have to look at this and we do have to treat it, how do we treat it? So it does depend on how severe the infection is, whether or not it's a mild infection, moderate, or severe infection. And the infection, according to the IDSA guidelines, as far as their definition, it would mean that includes two of the following items. So a localized swelling or induration of the skin, erythema, local tenderness or pain, local warmth, or purulent discharge, okay? A local infection, which would be the mild local infection, only involves the skin and subcutaneous tissue, without any deep involvement and no SIRS criteria. And the erythema also has to be between 0.5 centimeters to 2 centimeters around the ulcer, okay? So the diabetic foot infection usually has an ulceration, and then they'll have erythema around it. And so this is kind of small, if you think about it. 2 centimeters is pretty small, right? So usually in my practice at the hospital, I'm not seeing them present with this mild foot. They're usually presenting with a severe foot or a moderate diabetic foot infection. So for the moderate infection, it is those larger than 2 centimeters areas of erythema, and it can involve deeper tissues, which does include abscess or osteomyelitis, so that doesn't eliminate the potential possibility that they do need amputations there. For severe infection, you do have the above criteria of this moderate infection, but you're also seeing a lot more systemic symptoms, okay? So you're seeing some of the signs of SIRS, which we definitely do see these patients. I would say they're not the ones that are sitting up in the bed smiling, wondering why they're having to stay in the hospital to get intravenous antibiotics. Usually they're feeling a lot worse. So I would say I do see usually the majority of my patients do present with a moderate infection. And so usually they're presenting and they're wondering, why are we all so worried? But we're thinking we're going to have to amputate this, right? But they might not feel it. Okay, so how do we manage this? You do need to be getting culture and susceptibility because it is really important to be able to kind of narrow down your spectrum. I know that we talk about this all the time with everything else, but it's still very important with diabetic foot infections. The prevalence of MRSA in diabetic foot infections, or DFIs is short, ranges from 5% to 30%. So that's a pretty big range. 5% makes me think it's way less likely, but 30% makes me think it's a third of the patients almost, okay? So how do we know if we need to cover for MRSA? Usually I'm covering for MRSA, but in patients with prior long-term or inappropriate use of antibiotics, I'm going to cover for MRSA. In patients who have had a previous hospitalization or a long duration of the foot wound or the presence of osteomyelitis, or if you have a nasal swab showing that you're colonized with MRSA. These are all risk factors that the diabetic foot infection could be caused by MRSA. And again, these are polymicrobial, so it could be MRSA and whatever else is growing in there, okay? Risk factors for Pseudomonas would include a high local prevalence of Pseudomonas infection and warm climate, which is what we have here in Florida and San Juan, and frequent exposure of the foot to water, because that's where you're going to be getting Pseudomonas from the water. For mild infections, you're going to usually be covering with PO antibiotics. And if they haven't recently received antibiotics, you're going to empirically cover just for gram-positive cocci like MSSA and strep. For mild to moderate infections or in mild infections that have received antibiotics in the past month, you're going to be also covering for gram-negative rods, because that would be indicative of that you need to broaden your coverage, right, if they've received antibiotics in the past month. For moderate to severe infections, you do need to empirically cover for MSSA, and if it's severe, you do need to cover for MRSA, and then you're also needing to cover for Enterobacteriaceae and obligate anaerobes. So then you're starting to need to really broaden your coverage even more. That's when we start seeing Vosin again. Okay? So some of our new medications that have been approved for acute bacterial skin and skin structure infections, since 2014, and they came out with that treatment algorithm guideline. It's pretty prescriptive, I would say, for an IDSA guideline. So some of these things are new, and we're not sure where it fits into therapy. I think that there's a lot of debate over this, and on the IDPRN listserv, which is the ACCP ID listserv with all the ID pharmacists on it, this is a constant topic of consideration of like, when are we going to use some of these new agents? Because the guidelines don't really talk about them so much, and we're not sure where it fits into therapy. And I think this is still a debate right now. Where do they fit in therapy? Well, one of these drugs is Sevextro or Tadazolid, and it's a Me Too drug, just like linazolid, except for it has a little bit shorter of duration that you need to treat for. And the dose, IV to PO, same dose, 200 milligrams. It's once daily, as opposed to linazolid, that's twice daily, but it's a lot more expensive, so I don't really see this used. I've actually never used it myself. Advantages to using this would be there's no dose adjustment to renal or hepatic insufficiency, although you don't have to do that anyway with linazolid, so there you go. Oxazid there. Adverse drug reactions include nausea, vomiting, diarrhea, headache, and dizziness. And it covers the bugs that we normally need to cover empirically for a lot of these skin and soft tissue infections, including MRSA, okay? And it does have some anaerobic coverage as well. So does linazolid. Dalbavancin.
Is it generic already exist for Tadazolid?
No, generic does not exist to Tadazolid. It just came out in like 2014. So that's going to be another 10 years at least probably until we see a generic. Linazolid came out around the year 2000, I want to say, and we just got a generic this past year. So that was 16 years later. Because the pharmaceutical companies are a dirty business, but soapboxy, sorry. All right, so dalbavancin or Dalavance is a lipoglycopeptide. It's a newly FDA approved in 2014 for the treatment of exactly this indication, right? It is one of these long-acting glycopeptides. So it's similar shaped as like a vancomycin, right? But it has a lipophilic structure on it to make it kind of almost like depot-like, okay? And it's dosed as a 1,000 milligram dose over 30 minutes intravenously, and then a week later you come back for 500 milligrams. And then post-marketing, they realized that they were going up against Ortavancin, that's a one-time dose, so they decided to study it in a different dosing way. So they decided to study it with just using 1,500 milligrams once. And they showed that that was actually equivalent. So that's usually what I see on people's protocols when they're sharing some of these protocols to use dalbavancin. In these scenarios, they're going to be using the one-time dosing of the 1,500 milligrams IV once. There is a renal dose adjustment that is needed, and it's just a decreasing of the dose. There are potential hypersensitivity reactions, which would include anaphylaxis, which is of a pretty big concern when we're looking at a long-acting drug like this. But I don't know of anyone who's clinically seen this in their practice so far, so I'm not sure how those would generally be treated because it's a long-acting drug, right? The antimicrobial spectrum includes a lot of the main organisms that we need to cover for skin and soft tissue infections. So this seems like a pretty good drug option for that. But again, this is, I think it's $3,000 almost. I think it's about $3,000 for a treatment of this. That's kind of expensive. And then we go with Oritavancin or Bactiv. And this is also approved in 2014. So all these things came out right as guidelines were published. So that was unfortunate timing. This is not appropriate for osteomyelitis. In fact, in trials that they were looking at using Oritavancin, they saw an increase in osteomyelitis cases in the Oritavancin arm compared to the vancomycin. So we don't use this in osteomyelitis, and we're not sure if it's that the drug doesn't get there very well, or if it's not active there, or what's going on there. We still haven't figured out the mechanism of why that occurs, but I would not use this in patients with osteomyelitis, which is unfortunate because my patients with osteomyelitis need long durations of antibiotics. So in my dream world, this would be a great option for me to have the patient come in once a week and get an antibiotic for 6 weeks. That would be great. Unfortunately, that's not the case. We can't do that with this drug because we saw treatment failures in the osteomyelitis patients, and then we actually saw patients develop osteomyelitis while they're on this therapy. Very small amount of patients. But they might have had a pre-existing kind of subclinical osteomyelitis going on, and that's what they think happened in those clinical trials. And this is dosed, as I mentioned, it's a single dose, which is what led Dalbavance to do their trials to do a single dose. So these are direct competitors, okay? And they have pretty much the same spectrum of activity. Adverse drug reactions, very similar to vancomycin with that red man syndrome, it can occur with too fast infusions. So this actually has to be infused over 3 hours. So this is not a quick ED infusion, but you can do it in the emergency department, and that's where I'm seeing people propose its use. And so some hospitals in this area I know are recently looking into potentially making an algorithm, including using these, but I haven't talked to anyone that's actually done this yet, like successfully. I know that they've had a lot of pushback because I think oritavancin is around $4,000. So that's insane, right? That is not common sense to price drugs at that high of a level, but that's what we're dealing with as pharmacists. Imagine that's our acquisition cost. So that comes out of our budget, in the pharmacy budget, and if we're treating indigent patient populations and are not going to pay that bill, that goes onto our pharmacy budget and it increases our costs without us getting any money back from that. So that's usually what leads to people not adding this to their formulary. All right, so let's do a practice problem. I only included just like a little brief one because we're going to go over a bunch of practice problems together on Monday. So briefly, here we go. HG is a 49-year-old male with hypertension and hyperlipidemia. He presents to an urgent care clinic with a chief complaint of local edema, redness, and warmth of his left lower extremity. The physician notes that it does not appear to have any fluid or abscess associated with it, and so it can't be drained. So we can't do IND on this. And HD did not show any signs of systemic infection, including he has a normal temperature, and he doesn't have any drug allergies. What type of infection does HD most likely have? Sounds like cellulitis, yeah. So what is the most common cause of this infection? Strep, one of these strep species, right? What kind of additional information would you like prior to recommending treatment options? We already know he has no known drug allergies, right? History of what? Maybe a history of antibiotic use previously, right? Has he failed PO antibiotics? Because in that scenario, we would need to do something a little different, right? I would also want to know if he had any penetrating trauma to that area, suggestive of maybe it's not just strep, and I would maybe want to cover for something else, like a MRSA in that scenario. So I'd want to know if there was a penetrating injury there, which he didn't describe in this presentation. But those would be my types of questions there. This is a pretty mild infection that I'm describing here. And so he's going to be treated as an outpatient. Clearly, you probably picked that up based off of how they were presenting this patient, but that would also be an additional piece of information that you would need. So what would your recommendation be? Can you use the thing?
Penicillin.
A penicillin. Okay, you could use penicillin. That would be acceptable. And what dose and for what duration? Let me check. All right. Do I have anybody else with any other options? Anyone want to do Keflex? You could do cephalexin as well. You could do cephalexin, 500 milligrams PO Q6 hours. What if he had a penicillin allergy?
Clindamycin.
All right, clindamycin I'm hearing. Yeah, so you could use clindamycin in him too. All right. So, does anyone have any questions from this lecture, skin infections? All right, so I will actually post a Blackboard announcement when I post those cases just for you guys to know when to check for them. I'm hoping to get it done before my meeting this afternoon, but that's pretty ambitious. All right?